at home live stream. My name is Patrik Hutzel, and today's live stream is about, can you live on a ventilator at home? It's a question we get very frequently, and today I want to break it all down for you, especially if you have a loved one in intensive care, being stuck on a ventilator with a tracheostomy. But I know a lot of you also want to know, can you live at home on a ventilator with a breathing tube or an endotracheal tube? And I will break it all down for you in today's presentation. So, if you have any questions today, type them in your chat pad. You can also call in live on the show. I will give the numbers later. If you have questions, please keep them to today's topic, and I will get right to them. If you have questions that are not related to today's topic but are intensive care related, you can type them into the chat pad or call into the show later, and I will answer them then. A little bit about me. You may wonder what makes me qualified to talk about today's topic. My name is Patrik Hutzel. I'm the founder and director of Intensive Care at Home. I'm a critical care nurse by background. I've worked in intensive care / critical care for over 20 years in 3 different countries. I was part of pioneering intensive care at home in Germany in the late 1990s, early 2000s. And then I started a similar service in Australia as I was immigrating to Australia. And we have now had this service up and running here in Melbourne, Sydney and Brisbane in Australia since 2012. We are also helping clients in the US to try and get people home, even though we don't have a physical presence in the US yet. Same in the UK. We're trying to help people in the UK getting their loved ones home. Again, we don't have a physical presence in the UK yet, but we're proactively working on that. As part of my work in intensive care and intensive care at home, we're also running a service intensive care hotline where we consult and advocate for families in intensive care all around the world. And we have done so for the last 9 years. So that's a little bit of background before we go into today's topic. So today's topic again is, can you live on a ventilator at home? And we have named it Intensive Care at Home live stream. So why have we named it Intensive Care at Home? Because yes, you can live on a ventilator at home with intensive care at home. So let's describe the current environment a little bit more in intensive care. If someone is on a ventilator in intensive care, whether they're on a ventilator with a tracheostomy or with a breathing tube, they are in an ICU, in an intensive care unit, critical care unit, whichever term you want to use. Why is that? It is because ventilation and tracheostomy is life support, and it requires specialist skills. Keeping someone alive with equipment, with machinery, requires specialist skills, full stop. What are those skills? Those skills are, you need ICU doctors, ICU nurses, ICU physiotherapists, and so forth, right? That is the prerequisite to have an intensive care unit set up. Now, what happens in intensive care is that, people come in, they are critically ill, they have life-threatening illnesses that need, again, the specialist skills of intensive care doctors, intensive care nurses, physiotherapists, and so forth. Now, paradigms in ICU have pretty much been that there's 2 pathways for patients in ICU. The first pathway is you recover and you go to a hospital floor, hospital ward, and then you go home, or you go onto rehabilitation. The other pathway is people don't survive intensive care and die, and that's the end of that. Now, with intensive care at home, we have created a third pathway. We can successfully and evidently take patients home from intensive care with a critical illness, especially if they're long-term ventilated with a tracheostomy, but we also have intensive care patients at home that are not ventilated, but have the need of an intensive care nurse 24 hours a day. But to stick to today's question, which is, can you live at home on a ventilator? The answer is absolutely a clear yes. With the right support structure, which is what we're offering here at Intensive Care at Home. Now, how do we do it? So once we have inquiries either from hospitals, from intensive care units, or from families, we'll set up a team, we'll organize equipment, and we might even have to help you with organizing funding. But funding is much more easier now than it was 10 years ago, because the concept has been proven. There's research and evidence out there that we publish on our website how it should be done safely, or how it can be done safely, right? And then it's a matter of selecting the right staff members, okay? And what do those staff members need to have? We are hiring ICU nurses with a minimum of 2 years ICU experience, ideally with a postgraduate critical care qualification. And that's our minimum selection criteria. Furthermore, the average ICU experienced staff member we have is probably 8 to 10 years. So, we are literally employing hundreds of years of intensive care experience in our service, which, gives us a very strong foundation to having made that innovation to take patients home from intensive care, to provide the intensive care in the home. And having that skill set with hundreds of years of ICU experience in our service enables us to provide this service safely. So what does it look like at home? It looks like you need, from an equipment point of view, you need 2 ventilators, 2 suction machines, you need 2 monitors, you need spare tracheostomies, you need tracheostomy dilators, you need bag valve masks or resuscitation bags, but we can help you with organizing all of that. And we can also help you with obtaining the funding that is needed for such a service. None of our clients are really out of pocket. It's funded here in Australia predominantly by the NDIS, by the National Disability Insurance Scheme. But it's also funded by organisations such as the TAC in Victoria, or iCare in New South Wales, or the Department of Veteran Affairs. So there's different avenues for funding. And keep in mind, on an economic level, an ICU bed costs around $6,000 per bed day, whether that's here in Australia or in the US. Intensive care at home can probably be provided for around 50% of that cost. So really, it's a win-win situation for all stakeholders, whether it's the hospitals, whether it's the funding or the insurances, whether it's for the hospital who frees up a hospital bed, who frees up staff, equipment, right? It's a win-win situation altogether. So then you might be asking, how long can someone live at home? It really depends. It depends on whether someone is going home for palliative care, depends whether someone is going home for ventilation weaning, depends whether someone might be going home with a C1 spinal injury that is otherwise healthy, but if someone has sustained a C1 spinal injury, they're quadriplegic, and they are dependent on a ventilator for the rest of their lives. You can't wean those clients off the ventilator, but they can live a good quality of life at home for potentially for decades. So it really depends on the situation and what the goals of care are. And the goals of care really should be driven by you as a family or by your family member. What the goals of care are. Are they end of life? Are they quality of life? Are they even more aspirational, such as, does someone want to go back to work, to uni, if that's possible? We have had clients where it is possible, and we have clients where it is possible, but we also have other clients where, the focus is on end-of-life care. So it really depends on what you want. How can it be put in place? It can be put in place with a 24-hour nursing roster, similar to intensive care. Needs a 24-hour nursing roster, with 12-hour shifts, 8-hour shift. 8-hour shifts depends a little bit on, again, staff availability, depends on your preferences, probably also depends on location. So, it depends on a number of things. But the bottom line is that it needs to be a 24-hour roster without interruptions to keep things safe. Now, I mentioned earlier about evidence-based practice, and if you look on our website, intensivecareathome.com, you will find the mechanical home ventilation guidelines. And unlike in ICU, we are, I believe, the first organization worldwide that actually puts standards in place how intensive care at home can be done at home safely, and how it's also evidence-based. And if you look at the article, the mechanical home ventilation guidelines, it clearly says the only way it can be done safely is if you have an ICU nursing roster 24 hours a day, and all those ICU nurses need to have a minimum of 2 years ICU experience, right? It's clear cut. Otherwise, we couldn't name our service intensive care at home, right? It's as simple as that. Now, coming back to our original question, can you live at home on a ventilator? I've answered the question already. I mainly focused in the last few minutes on ventilation with tracheostomy, but there's also another situation where patients can live at home on a ventilator without a tracheostomy. That's if they are BiPAP or CPAP dependent. We have a number of clients at home that are not having a tracheostomy, but are having BiPAP ventilation with a face mask. Okay, and again, if you look back on our mechanical home ventilation guidelines, it's the same guidelines apply here, that if someone is at home on a BiPAP machine, that they need intensive care nurses 24 hours a day to make that possible, to keep them out of ICU and manage them similarly to an ICU patient, but obviously in a much nicer environment, in a home care environment surrounded by their family. It's such a better environment. And we know that all of it really at home is driven by the families. How do they want the routine being done? We try to get them involved in staff selection. We're working in collaboration with our clients to make it a win-win situation for everyone, so that the clients can stay where they want to be, which is their home. I just want to take a quick breather here and just want to find out if there are any questions so far. If you have any questions, you can type them into the chat pad, or I'll now give you phone numbers. You can also dial into the show if you like. I'll give you the phone numbers now, and then you can dial in and we can answer your questions on the show. If you are in the US, you can call 415-915-0090. That is again for our US audience, 415-915-0090. For our Australian viewers, you can call 041-094-2230, 041-094-2230 if you're in Australia, and in the UK, 0118-324-3018, 0118-324-3018. Coming back to, how you can live at home on a ventilator. So I've broken it down to if you have a tracheostomy and a ventilator, and I've also broken it down if you need BiPAP or CPAP at home. Often when patients are at home on BiPAP or on CPAP, they also have other medical needs such as seizure management. They might have type 2 respiratory failure, they might have asthma or COPD, and we need to manage that together with the medical team, with a care plan, with medications that are being given, with all the equipment that is needed, and again, with a 24-hour nursing care roster, making sure that it's a safe process going, a safe transfer going from ICU to a home care environment. And again, it all comes back to the home mechanical ventilation guidelines that I link to below when we publish this video. Now, also, we have a lot of inquiries where families say, hey, my family member has been in intensive care for 3 days, they're on a breathing tube, can I take them home? Now, as much as we would like to do that, it wouldn't be the right time to take someone home unless it's for clearly end-of-life care. But it's often probably too early after 2 days in ICU, 3 days in ICU to see what the next steps are. It needs a little bit of time, and we also need a little bit of time to get ready to take patients home. Can you live at home on a breathing tube, on a ventilator? Only for very short periods of time. You can live at home on a ventilator with a tracheostomy for a very long time. The simple reason is this: a breathing tube can only stay in for 2 weeks, 14 days max, and then if someone can't come off the ventilator for whatever reason, then you need to look at doing a tracheostomy. So taking someone home on a breathing tube is very risky, because if the breathing tube came out, for example, we wouldn't have the skills and the resources to do a re-intubation at home. Whereas if the tracheostomy came out, that can be reinserted very quickly, and we are trained and competent to do so. Not so much with the breathing tube. It needs an intensive care specialist there 24 hours a day. And a breathing tube also requires an induced coma or sedation, whereas tracheostomy, generally speaking, doesn't require an induced coma and sedation. So you want to have your loved ones at home being awake. Whereas with a breathing tube in the throat is so uncomfortable that it needs sedation and the induced coma. Therefore, it's very difficult to make that happen at home. Now, there is one exception to that rule. There is one situation where people can go home on a breathing tube. We have basically provided end-of-life care at home for patients with a breathing tube. And that is predominantly for a quote-unquote one-way extubation. What do I mean by that? So sometimes in ICU, patients are end of life and they might have a breathing tube, and for whatever reason it's being decided that it is actually the only way forward is to take the breathing tube out and let patients approach their end of life by taking the breathing tube out. And a lot of families in ICU think, well, we can accept that because we think, that is what's happening here, but we don't want that to happen in a hospital. Can't we have that at home? So, and yes, that is the exception to the rule. We have provided end-of-life care at home for patients with a breathing tube or endotracheal tube, where we take them home, we take the breathing tube out at home, and then, we can let patients approach their end of life at home. We have palliative care involved. We make sure that patients are comfortable, that pain is well controlled, that they're sedated well enough, and so forth. So that's how we do this at home. That is the exception to the rule. And, that's what we can provide in this situation. But intensive care at home predominantly is for long-term ventilated patients with a tracheostomy, because you've got a safe airway. Okay, so Helene, nice to see you again. You're asking, how often does the inner cannula need to be replaced? When late mum was in LTAC, the facility did not have the cannula, therefore respiratory tech sanitized the cannula. Okay, great question, Helene, and very topical. So, interestingly enough, some of our clients at home have an inner cannula and some of them don't. Most pediatric clients do not have an inner cannula. Some adult clients do have an inner cannula, but and then we need to change it. But again, some of our clients don't have inner cannulas. So if they don't have an inner cannula, it's very important that they get regular nebulizers, regular suction, and that the nursing staff inspect the cannula regularly, so that there are no blockages. If you have an inner cannula, like was the case with your mom, Helene, it needs to be changed, I'd say, once a shift, every 8 hours at a minimum. I have seen clients where it needs to be changed every 4 hours. Let's just quickly make the distinction when to use an inner cannula and when not to use an inner cannula. So some of our clients that don't have an inner cannula don't have a lot of secretions. Let's just put it that way. The clients that have an inner cannula, generally speaking, have a lot of secretions. And if you have a lot of secretions, chances that the cannula or the tracheostomy blocks are much higher, which is why you need to change it more frequently. If someone without an inner cannula had a lot of secretions, the risk of the tracheostomy blocking is much higher than with an inner cannula, assuming you're changing it quite frequently and every 4 to 8 hours. But a lot of it really depends, the way to assess that, Helene, is really you take out the inner cannula, you have a look, and you actually see whether it's soiled. And you look through the cannula and see whether it's narrow and whether it needs to be changed or not. That's the way to assess it. And once you get to know a client, you also know what the likelihood of the inner cannula needing to be changed 3, 4, 5 times a day. You get into the habit of it, and because you know a client's routine, right? So I hope that answers your question. It's sort of, for pediatrics as well, they don't have an inner cannula because their tracheostomies are too small, right? So it's predominantly for adults where inner cannulas are used, and most adults actually have an inner cannula. There's the rare exception where they don't have an inner cannula. I hope that answers your question. But in both cases, whether you have an inner cannula or you don't have an inner cannula, nebulization is really important. Humidified air or humidified oxygen is very important to not have secretions dry up in the first place. The worst thing that can happen really, and that doesn't matter whether it's at home or in an ICU, is that the tracheostomy blocks. That is the worst case scenario, and you need to avoid that at all cost, right? And that's what you do with nebulizers, that's what you do with humidified oxygen or humidified air, and that's what you do with inner cannula changes. Other options, for example, for someone without an inner cannula is, and we have one client where I can actually give a very good example, is to use a cough assist machine, because that's putting a lot of pressure down the lungs, may also, sort of clean the tracheostomy a little bit. And what also happens is some of our clients, or one client I should say, doesn't have a blocked cannula, which is very unusual for an adult. The cannula, the tracheostomy tube is not blocked, right? And then a lot of secretions actually run down the nose because there is no blockage, the secretions can also blow up the nose and then down the nose. And that also makes it less likely that the tracheostomy tube is blocking because less secretions accumulate in the tracheostomy tube. Okay, so I hope that clarifies that. I should probably also talk a little bit about if you want to call in, sure. 415-915-0090, that is again 415-915-0090. You can call in if you like. So should also talk about a couple of case studies. We have a lot of case studies, but so that I can illustrate what it means for someone to live at home on a ventilator. So, for example, we have some motor neuron disease clients at home. Motor neuron disease is a progressive neuromuscular disease, and there are 2 of our clients that live at home on a ventilator with a tracheostomy, and they came home after very long ICU stays until we had set up intensive care at home, until the funding was organized. And now they both have been at home for, I think, coming close to 3 years now. And, they live surrounded by their families. They're both very young. motor neuron disease is something that, you know, often happens very young in people's lives, in their 30s or 40s. And just give me 1 second. Hi, Helene. How are you?
I'm okay, Patrick. How are you?
Very well, thank you. Thank you for calling into the live stream. I appreciate that.
Oh, you're welcome. Give me one moment.
Sure.
Okay. You had made a comment about that there could be drainage out of the nose
Yep.
or mouth. And you said that can happen when now?
Predominantly for clients or for patients that don't have a blocked cannula.
Gotcha. Okay, well, let me ask you this. Because that happened to my mom when she was at home, and she at that point, she was off the ventilator. She was at home. She was breathing pretty much 98 to 100% on room air. Remember, her O2 test was around 98 to 100. However, I remember, well, there was two things going on. But one morning, I awakened and I found that she had all this drainage that came out of her nose. I first it came out of her nose in her mouth. Remember I shared with you she had a bypass machine injury where they had her on the bypass machine beyond the necessary need, and it caused her saliva gland to become overactive. So it was pouring out like water.
Right. Wow.
I had, pardon me?
Yeah, no, I'm just acknowledging what you're saying.
Yeah, okay. Also, that's why I had and they gave her, they prescribed her fentanyl patches that was to be changed every 72 hours, but they never told me what it was. It was addictive. It was an opiate. They lied about that to me, because you shared with me there could have been there's another option to dry up the saliva, when it's overactive.
There is. So let me ask you two questions and I'll come to what can be used to dry up saliva. It needs more explanation than just drying up saliva. But let me ask you this. Did your mom not have a blocked cannula? Do you know?
When she was at home, no, because she was, even when she went to LPAC, she was already on a T-piece. When she was at the hospital, the doctors, the pulmonary doctors and the hospitalists, they were trying to cover up their malfeasance, malpractice, and she had suffered a brain injury. And as a matter of fact, I don't even know where it is. They gave her so much drugs, it caused her to suffer. I call this hypoxia encephalopathy, but there's one that is induced by too many narcotics. I can't remember the name, and I have my notebook with it in my briefcase, so I don't want to run away and
But
get off the call to do that.
sure, but I mean, but I mean that's not the first time that someone, you're basically describing an overdose from opiates. Is that what you are describing?
Oh yeah, opiates.
Right.
I mean, they gave they induced. Like I said, my mother was forced on the ventilator. Give me 1 minute. Let me see if I can get my notebook. I have to write the word down.
Right. Okay. But while we're waiting for Elaine, I'll just keep talking in the meantime.
Give me 1
So,
moment. It was like toxic metabolism, encephalopathy. Does that make sense to you? Does that ring a
well,
bell?
yeah, not necessarily in combination with an opiate overdose. It could be, but I probably would need to know more. But look, an
Well,
opiate.
they were giving her overdoses. They were giving her overdoses. Overdoses of antibiotics, overdoses of chlorhexidine. They were giving her. They even gave her propofol. to, under false pretenses, to get her on the vent because they were covering up malpractice, injury that happened on the bypass machine, where I told you she chewed off a piece of the mask and it was blown down her throat and cut her esophagus, which caused an infection, septic shock, and then they tried to discharge her abruptly, and it was an unsafe discharge, but I refused to take her out because I saw her physical deterioration, and she was very lethargic. They were trying to send her home so they would not be liable. But the name of it's something called, I'm gonna spell it out for you. Another word I found was MITOCHONDRIA, and it says if damages been recognized as a cause of death from the side effects of critical
some mitochondrial.
Side effects of drugs.
Right. Some
Yeah.
mitochondrial.
So they. Go ahead. I'm sorry.
Some mitochondrial damage by the sounds of things, which is often sort of a neuromuscular thing but it's very detailed. It's more of a question for a doctor than for me in this situation. But
but I'm just saying that was one of the things I believe that happened because the thing is for her to have been given fentanyl under false pretenses and it was the wrong medicine. There was no way she was going to get weaned off of fentanyl. Young people have a hard time getting weaned off fentanyl.
Fentanyl should only be given in the short term for, if someone comes into ICU, needs to go into a coma, has a lot of pain. It's more for the short term. It should not be used for the long term, ideally. But I know there are people on fentanyl long term as well, unfortunately.
Yeah, but at least, the thing is, that's the whole point. They never educated me on it either. They sent her home. I asked, how long will she be on fentanyl? Oh, they said, well, let her primary care doctor make that decision. So I was always kept in the dark, which put me at a high risk to be negligent. But fortunately, I wasn't because I was very in tune to my mom, and when something was off, I was definitely advocating to get help for her. But still, that's it's already stressful enough being a full-time caregiver, and see, I didn't have anyone helping me with my mom. I had to do it 24/7 with God's grace and mercy, because I surely wasn't equipped, but that's the other part that really bothers me, that, not only do they, some pulmonologists or primary care doctors in the hospital, in ICU, withhold information from you, they don't even prepare you, they didn't prepare me for, what was to come with my mom.
And nobody,
I had to figure it out on my own.
Nobody will prepare you for what's to come, and that's why I keep saying the biggest challenge for families in intensive care is that they don't know what they don't know. It's very hard to predict, and it really comes down to asking the right question in the first place, and that's very difficult, of course. Now.
If you don't know what questions to ask,
that's
how
right.
do you ask the right questions? And that's the part. And see, my mom, when mom first went on a vent, and it was also induced, malfeasance, malpractice was in 2012. I don't think you came into play into
2013. 2013, I started going online.
Yeah. And then in 2016, I didn't even know about you. And that's the other thing. How a lot of people don't even know how to find you, or your company.
Yeah, no, for sure.
That's the part.
For sure. It's getting better, and we have no shortage of work, Helene. You know, we definitely have no shortage of work. Now, I do want to come back to you. I've just got another question here in the chat pad that I quickly want to answer.
Great.
Sorry. So, Alpha Rayon 83 is asking, hello, my father died on a ventilator from a cardiac arrest. Is that common? That's a very broad question. People die in intensive care on a ventilator from cardiac arrest. But I should also mention to you that only about 10% of patients in ICU do not survive. So 90% of patients do survive roughly. So it's people die on ventilators with cardiac arrest, but I would need to know more to really understand what was happening, you know, what led to it, why was your dad in ICU in the first place. So I wouldn't say it's common. You know, I looked after thousands of patients in ICU, and I would say only a small minority of them have passed away on a cardiac arrest. Oh, he was in a nursing home. Again, I would need to know more about, you know, what was his underlying condition, you know, before I can answer the question. But I can tell you, it is not common that patients die with a cardiac arrest on a ventilator. It's not common. That much I can answer you. Sorry, Helene. So I just had to answer this.
No problem.
Now,
No.
you mentioned earlier about. Please.
Let me ask you one thing real quick. My original question was the drainage.
Yes. Yeah.
There was so much drainage on her pillow. I mean, it was soaking wet. And my question, you know, I was wondering, did it come from the excessive fluid overload? Like if they give somebody excessive fluid overload, and it can still be in their bodies, how? And they don't urinate it all out. Can it come back up through their esophagus? Can it come up through their nostrils? I mean, how does all that fluid?
How is it?
Come out of the body?
Great question. So there's a number of things there, Elaine. On the one hand, yes, there needs to be a very tight fluid balance, you know, need to watch what's going in and what's going out every 24 hours. Was your mother in kidney failure?
They were trying to induce it, but thank God she did not have kidney failure.
Okay.
There were one thing I've learned, some illnesses are driven, you know, which I mean they are inducing it because they make money. And see, that's what my mother was constantly being a victim of. It was driven because, like I shared with you the last time we spoke, there were times they would order, her PCPs will order a hold on water for like 3 days. And there was no reason to do that, but to induce her metabolism to get off track where she needed salt pills, or they totally discontinued water and gave her saline indefinitely in her peg tube, which is not even for human consumption. I mean, so that's where a lot of foul play was happening. And that's where, you know, I get, that's where, you know, for me, I love talking with you because there was so much done that was egregious and it was malfeasance to cause damage and harm. You know, I have to take what I remember happening and bring it back to what should have happened. That's why I asked you the question, because it's almost like brainwashing, like this is normal, but it's not normal.
No, it's not normal. By the same token, Helene, a lot of patients in ICU look like they are fluid overloaded simply because they are immobile.
Well, she really was, because I did advocate to have her to be moved, you know, for physical therapy and all that. The hospital, well, they said the insurance company would not pay for it. So what they was willing to do was let the physical therapist come in and show me how to do most range of motion exercises. And I also advocated for her bed to be put in a position like a chair so she can sit up so it can expand her lungs so she could breathe better. And this was like God sent because I don't have a clinical background, but I knew it was logical.
Right.
You know,
Elaine, there's
it
probably
was just common sense.
right. There's probably more to it though, and I'll tell you why there's more to it. So,
Okay.
a lot of patients in ICU or in LTAC, they have low albumin. Okay, albumin is a blood product, and if albumin is low, people are swelling up. Okay, that's probably another reason why your mother was very swollen. I argue that 8 out of 10 ICU patients have a low albumin, and the combination of them being immobile and low albumin gets them to swell up. Next.
I can understand that, but you have to be an eyewitness them giving her the excessive fluid overload. I saw this as a pattern, and to make it look like she had edema and congestive heart failure. Plus, she was being seen by a cardiologist who documented and wrote a paper prescription for me to give to anybody whenever she went to the hospital, that she only have edema or congestive heart failure, which when she's in the hospital from excessive fluid overload. So that is factual.
Yeah, no. Look, I'm sure it's very factual. Now, other question here, Elaine. Did your mother have heart failure?
Yes, because of the excessive fluid overload.
Right. Well, I guess it's almost a chicken or egg question. A lot of patients in ICU that have heart failure are also ending up with fluid overload.
Yeah, because it's congestive heart failure. That makes
Correct.
sense.
Correct.
But that wasn't the case with my mom. They were intentionally giving her excessive fluid overload to cause respiratory failure.
I see.
That's what I'm saying. My mother was treated like a commodity. They were making money off her. She was being medically exploited. And I saw this happening time and time again from 2012 to 2016. And many times I was able to stop it because I saw she wasn't dehydrated. Because I would ask, is she dehydrated? And I asked, what were the numbers for somebody to be dehydrated? And many times she was not.
Right. Okay.
That's why I'm saying she was forced onto ventilators. She was forced to have those procedures where they stick the needle in the back of to your lungs and drain that fluid off. See, I saw this malfeasance, malpractice that was manipulated. That's why I stand so strong about what I'm saying, because I know I saw the pattern.
Yeah, for sure.
And that's why, I had to file a lawsuit in the federal courts versus the state, because it shows, being that they're inducing illnesses for profit, that is a felony. That's an assault and battery.
Right. Helene, I do have more questions in the chat pad that I want to get to.
I'll hang up and I'll listen. Thank you.
Okay, thank you so much. Thank you for your input. I really appreciate it. Thank you for sharing this.
You're welcome.
Thank you. Bye.
Bye-bye.
All right, let's get back to your questions in the chat pad. It was really nice for Helene to share what she's been going through. So Alpha Rayon 83 had a question earlier whether it's common for someone on a ventilator to have a cardiac arrest and pass away, and I said it's not common at all. It's, I don't know your dad's clinical history, but so then you are saying he had pain because of bed sores. They were heavy pretty good, almost completely. Then the last 3 days, hang on, it's disappearing. Then the last 3 days of his life, he was breathing faster, sometimes at 60 breaths per minute. I visit him every day for 3 hours, and we did exercises every day because Medicare didn't pay it. Okay, so coming back to your original question, Alpha Rayon 83, it's not common for patients on a ventilator to have a cardiac arrest. I mean, as we all know, our earthly lives are limited. At some point, we're all going to die, right? But, you know, it's not common for someone on a ventilator to have a cardiac arrest. That much I can tell you. The question is, did he have a cardiac history? You know, was there anything wrong with his heart? Do you know? Also, probably would be interesting to know, how old was your dad? How long was he on a ventilator to begin with? Those would all be questions that would help me to answer your question. It would be interesting to find out if he had any cardiac history specifically. And you're saying last 3 days of his life he was breathing faster, sometimes at 60 breaths per minute. You know, was he in pain? You know, did they send him back to the hospital? What was, what was the background? He's saying, not that I know. Okay. All right. So Jennifer has a question. Any advice for someone weaning at home that seems mentally dependent on the ventilator but physically clear to get off? Great question, Jennifer. Great question. So I would argue that a lot of patients, especially in ICU, not so much at home, and I tell you why I think it's not so much at home, but that they're mentally dependent on the ventilator but are physically clear to get off. There's definitely a physical component on being on the ventilator and being dependent on it. So I'll give you some examples that I can illustrate that for you. So when someone is in ICU or at home on a ventilator, and let's just say you take them off for a few minutes and they can't cope, and all of a sudden they feel like they can't breathe, can be very traumatic for them. So then you put them back on a ventilator, but they don't want to repeat that traumatic experience because, you know, they might feel like they're going to die. And that can be very, very traumatic. Then you might give them some sedation, something to calm them down. Then they might get mentally dependent on that. So it's almost like a vicious cycle that people need to get out of. On top of that, you know, the trauma, the mental trauma they sustained in ICU, just of being there, being in an induced coma and so forth, you know. You could also argue, should antidepressants being used? You know, I do believe the best case is to start all over again very slowly, you know, take someone off the ventilator for 2 minutes, maybe increase then to 4 minutes, then increase then to 8 minutes. I do believe that is the best approach. You know, it's also important that they are in a regular day and night rhythm, that they can sleep at night and be active during the day. Okay, so then Jennifer, you're adding on Dad doesn't know whether he's in AC or SIMV. He hates CPAP. He's oxygenating at 96 or above and says he can't breathe. Okay, can you give me a little bit more detail there, Jennifer? Why is your dad on a ventilator? How long has he been on a ventilator for? Can you share some insights there? And also, is your dad at home already, or is he still in the hospital? If you can, he's got hypercapnia, yeah, sure, I can get that. And that's why he hates CPAP, that makes sense. Why is he on a ventilator? Put on June 2021, but why? Just the hypercapnia? I wouldn't think so, there must be more to it. Home since October. Okay, and why is he on the ventilator in the first place? Is it COVID? What led him? COPD. Okay, so he's got COPD. Okay. And he doesn't like CPAP. Okay, I can tell you straight away that with COPD, you might want to try BiPAP instead. And the reason you want to try BiPAP instead is simply, for someone with COPD, you're having a high CO2 or a carbon dioxide, okay? High carbon dioxide, you can better eliminate with BiPAP than with CPAP, okay? If the CO2 can't be eliminated, your dad might get confused, agitated, and that might just exacerbate the mental dependency on the ventilator. Okay. He was your dad, Jennifer, you're saying your dad was originally diagnosed with COPD, then a month later, 9/11 to hospital unresponsive with 88 ABG. 88 CO2 or 88 PO2. That's it, nothing more than never been. That's, yes, so 88 CO2. Okay. Yeah, okay, sure. So at that stage, Jennifer, did he have a tracheostomy already at that stage when his CO2 was 88 and he went and you had to call 911? Did he have a trach already? In any case, whether he had a trach or no trach, I would argue, not yet, yeah, okay. I would argue you got to try BiPAP because that will help you eliminate the CO2 most likely. So if he's on CPAP, and even with the SIMV, if he is in an SIMV mode, you probably have to look at what's the rate. Also important, is he in a volume control mode or in a pressure control mode whilst he's in SIMV? So maybe try BiPAP, but try BiPAP with the same rate than SIMV. If he's getting a rate of 15 breaths per minute, for example, with SIMV, PEEP 5, 8 rate, a rate of 8 for someone with COPD, I argue, is too low. It's too low. Try BiPAP with a rate. I don't know who manages your ventilation settings. Bear in mind, I'm an intensive care nurse. I'm not a doctor, but I'm talking from experience here. I'm not talking because I've prescribed anything. I'm not qualified to prescribe ventilation settings, but I am telling you from experience that for someone with COPD, with a high CO2, and you might try BiPAP mode, PEEP of 8, pressure support of 15, and maybe a rate of 15 breaths per minute, and see what happens. And I don't know where you are. It sounds to me like you're in the US, Jennifer, but if you are in Australia, we should definitely talk about helping your dad at home, but it sounds to me like you're talking about 9/11. I would think that you are in the US, but if you are in Australia, I would definitely like to talk to you because I'm certain that, yeah, you're in the US. That's okay. That's okay. I hope I can still help you with this. So that would be my advice. And Jennifer, do you have, does your dad have a lot of hospital admissions, or have you been able to keep him at home so far? Look, Jennifer, we're probably halfway there to get the program to the States. Look, the limitations for us at the moment are we are so busy here, we can barely keep up here. And it's also, we need to invest some money to go to the US, and we need to find the right location to start out in the US. We have inquiries from all over the country, but some, we have more inquiries from some locations than others. Since December, he's been home and doing well. That's great. That's great. That's fantastic. That's fantastic. So, it's definitely possible to live at home on a ventilator with a tracheostomy, but it takes work. It's ongoing, it's non-stop, and you definitely need to know what you're doing, and you need to have the right support structure in place to make it happen, So I hope that Jennifer, so November the 2nd, 9/11, Colds mucus issues, LTAC sent him home with an infection without telling us. Right. Well, I would hope, Jennifer, that at home he's infection free because you're in a much cleaner environment. At home is a much cleaner environment. Oh, it's a pleasure. It's a pleasure, Jennifer. Always happy to help wherever I can. Okay, I think we've been going for an hour now. And if there are any more questions, please type them into the chat pad now. Otherwise, I do want to wrap up in a minute. Any final questions I will take. I will do another YouTube live stream again next week around the same time, 8:30 p.m. on a Saturday Eastern Standard Time, 10:30 a.m. on a Sunday Sydney, Melbourne time. Jennifer, you're saying, I'm really strict on tracheostomy care, of which you didn't get much in LTAC. No surprises there. No surprises there. Unfortunately, LTACs are just better version of a nursing home. You know, maybe that brings me back to our question from Alpha Rayon 83. You're asking, you know, is it common that people die on a ventilator with cardiac arrest? Not at all. But you also mentioned that your dad was in a nursing home. Nursing home is one level down from LTAC. LTAC is pretty bad. Now you're telling me your dad is in a nursing home. I wouldn't be surprised if simply they didn't know what they're doing there. You know, you can't have lay people looking after someone on a ventilator. You just can't. That's why I mentioned earlier the mechanical home ventilation guidelines. That's the only safe way to look after someone at home on a ventilator or in a nursing home for that matter. You're saying, Jennifer, they rarely change things. It was a nightmare. Yeah. No surprises there. No surprises there. So yeah, look, I do want to wrap this up. So yes, next week, same time, US, Saturday night, US, 8:30 p.m. Eastern Standard Time, 5:30 p.m. Pacific Time, 10:30 a.m. on a Sunday, Melbourne time, Sydney time here in Australia. Unfortunately, it's in the middle of the night in the UK, but you know, the live stream here will be uploaded and you can watch it retrospectively. Jennifer, you're saying, if I can help get your program here, please let me know. I respect you and your help expertise. It's not so much that we could start in the US pretty quickly. It's a matter of having some manpower, female power, whatever you want to call it, and a physical presence. That's our next step. Go and check out intensivecareathome.com for more information. Also check out intensivecarehotline.com, where we advocate and consult families in intensive care. I also offer one-to-one consulting and advocacy for families in intensive care. Again, I'll put a link below this video. I want to thank you for all your support. Share this video with your friends and family. Subscribe to my YouTube channel for regular updates and regular live streams for families in intensive care and intensive care at home. Click the notification bell. Also, check out our membership for families in intensive care at intensivecaresupport.org. We also offer medical record reviews for families in intensive care. Again, we'll put a link below this video. Thank you so much again for watching this video. I wish you a wonderful weekend, and I'll talk to you next week. Take care. Thank you.